Welcome to the Shuman Show.
Thank you for having me.
Of course, brother. Who am I here with?
You're here with Dr. Joel.
Dr. Joel. Tell us a little bit about yourself and what you do, Dr. Joel.
Sure. Thanks for having me, Drew. So I am a preventative and emergency medicine physician, and I focus on cardiometabolic disease prevention, most specifically, and evidence-based hormone optimization.
I love it. We're going to have a lot to talk about today. I got a whole list of questions lined up.
Sure.
Before we get into it, I know we were just talking about your experience in the ER. What is that like?
It's pretty crazy. Fortunately, I'm dialing back a lot. I've been practicing emergency medicine for almost 12 years now. It's a pretty stressful job, and now I'm more in the health and longevity space. Mm-hmm. So that lifestyle kind of contradicts what I'm trying to do from a lifestyle perspective. So just to put it in a little perspective, really high energy, adrenaline, multitasking at its finest. And I was talking with someone about this the other day. They asked me, what's the hardest part of my job? And it's not really dealing with the life and death situations, the trauma, all that. I mean, that stuff is very difficult to deal with, but you're trained to deal with that, right, over time. For me, it's been the fact that my circadian rhythm gets so messed up, having to work. Sometimes my shift is 6 o'clock in the morning, and then, or it'll be at 10 o'clock in the morning, or then it'll be at 4 p.m., or then it starts at 7 p.m., and then I get off, in the middle of the night or early in the morning. So it's really hard to establish a good sleeping pattern, even if I'm trying to sleep 7 hours, 8 hours a night. So that's definitely the most challenging part of the profession, and it carries over into personal life. I worked 6 or 7 shifts a couple weeks ago, flew back to Miami, and I'd been off for a couple days, and I'm so sleep deprived, and I'm trying to get a good night's sleep. I went to bed at I think I went to bed around midnight. Yeah. And then I'm up at 4:30, 5 o'clock in the morning. I'm just up, and I'm so tired. I'm like, why is this happening? It's because I'm not going to bed, at a consistent time. So we really take that for granted. For people that are able to have a normal sleep schedule, if you have a job like me, you can't make that happen.
I definitely take that for granted. So thank you for that perspective here. Tonight when I'm in bed, I'm like, I'm grateful.
You should be, man. You should be grateful for that. Of course.
Yeah, and I mean, it's such a crazy environment. I mean, I've only seen it from being in the hospital in certain moments in the ER. It's like the energy and the fluorescent lights, and I really salute people like you, because we need people, right, in the ER, but it's not an easy environment to be in.
For sure. And you got those cool shades on right now. Yeah. I love that. I geek out, and I wear my blue light blocking glasses in front of the computer late at night towards the end of my shift, and everyone's looking at me like I'm this weirdo. I'm like, I gotta start dialing down, getting ready for sleep, right? But just the little things.
Yeah, it's fascinating to me though. A lot of people in that environment don't think about those types of things. Mm-hmm. You live such a healthy lifestyle, and now you're building a business around that, but you don't really see a lot of that in hospitals, in the ER specifically. Right,
because you're at the complete opposite end of the spectrum when it comes to healthcare, right? Emergency medicine is when things are under fire. Chronic disease has fully blossomed and gone haywire. So you're trying to put out fires, right? So you're dealing with people that often, that's why I started my company, is this huge disparity of what we see, what the patient, the population knows, and what we teach them as providers in healthcare. People there's a huge disparity of knowledge, what needs to be done to actually prevent yourself from getting chronic disease. And the good news is most chronic disease is a very slow and silent process. So the time for intervention can happen at any moment, but when you see people in the ER, people already have full-blown chronic disease and they're symptomatic, and you're having to treat that.
Yeah, totally. And I think there's such a big push for this preventative care, right? Because we don't want sick care. We don't want to treat people just when they're sick. We want people to be healthy and stay healthy.
Right.
Was there a certain moment when you were going down this career that you realized, I need to change this? I want to help people stay healthy and not treat them when they're already sick.
I don't know that there was a certain moment for that, to the shift. I've always kind of had it ingrained in my blood. You know, I've been a very healthy person ever since I was a kid. You know, I'm 43 years old now.
You look amazing, bro.
Thank you. I've been exercising for 32 plus years, always cared about what I put in my body. So the lifestyle aspect of health has always been something that I've been fascinated about, been passionate about. And unfortunately, our healthcare system is not set up to integrate lifestyle optimization and medical care. The two don't interconnect, and it's for a number of reasons, right? One of them is the payer system. Insurance doesn't reimburse for lifestyle optimization coaching, and that's unfortunate, because that's what really drives optimal health, is learning about what you can do from a lifestyle perspective to keep yourself healthy. But if you're sitting in a 5-10 minute visit, whether in the ER it's less than that, but even just in a primary care doctor's office, you don't have that time to really educate a patient, empower them to teach them about disease prevention. Often you're going to a doctor when you're already symptomatic, you're going for a specific problem. And in that short window of time, it's much easier for the doctor to say, hey, take this pill, you have this problem, this disease process, and I'll see you in a couple weeks. And it's not because the doctor doesn't want to help, it's just because the system wasn't designed that way, and you're not reimbursed for your time for prevention. You're reimbursed, your ICD codes, which is what you bill for, is all based on disease process, not on prevention.
Break that down a little bit. What is ICD code? I've never
So ICD is, think about it like diagnoses that we put into the computer system that gets sent to insurance for reimbursement. So if someone, for example, has diabetes, you do a visit for someone with diabetes, and you put an ICD code for hyperglycemia, and they have diabetes, then you get paid for that. The insurance reimburses you a certain amount, but they're not going to reimburse you for diabetes prevention care. And that also takes a lot longer to talk about the proper nutrition, getting to an ideal body weight, sleep patterns that you need to exercise in order to improve your insulin sensitivity, things of that nature. You don't get reimbursed for that. So it's a systems problem more than anything else. And a lot of what I learned from a lifestyle perspective wasn't taught to me in my medical training.
I hear that all the time, and it's so sad to me that it's a system problem. There's no incentive, right?
Right.
And how do we, from your perspective, how do we change that?
One, you need to take ownership and take empowerment for your own health, ask questions. And I think as a population right now, we're doing that. I think maybe it's just from like what I see on social media and what's filtered to me, but I feel like people are much more aware of their health now, and they're wanting to get healthier. So
For sure.
Asking those questions, learning, educating yourself, I think is the first place to start. Or I think things are a little bit dangerous is there are a lot of people out in this place that are bad actors that put out a lot of misinformation. They can be extremely influential, articulate, but the information is false. So if you don't have the way to actually validate whether the information you're looking at is true or not, that can be very, very dangerous. So if it sounds too good to be true, if people are talking in extremes and someone's trying to sell you their supplement, elixir, potion, that it's probably too good to be true. And what we'll talk about later, and I'm sure you'll get into this, is lifestyle optimization matters most. And there really is no biohack for that. Like, you have to do the basics if you want to pull on the biggest levers in health.
I love that. And I guess from your perspective, what is lifestyle optimization? What, if someone's coming to your practice and coming to you, what does that look like? What are the first steps?
Sure. So my lifestyle pillars are sleep. So optimizing sleep is often someone's lowest hanging fruit. Most people don't have their sleep dialed in. You know, on average, most people need 7 to 8 hours of sleep. Obviously, there are outliers of that. So getting good sleep hygiene, going to bed same time every night, making sure you're in a cold environment, dark environment, things of that nature. So sleep, getting that dialed in, having a way to quantitatively measure the quality of your sleep, whether it's through a wearable, can be quite helpful. And it's also can be motivating just to kind of help you tweak different things if you need to. The biggest thing that we see, where I'm seeing right now in the health and wellness space, where I have issues with, is what we call anecdote. Anecdote means that you have your own subjective measurement of how something is doing, right? There's a lot of anecdote out there. But if you really want to validate something and do it for the masses and not just the individual, you have to have objective outcome measures. You have to be able to quantitatively measure that something is improving, because if you're just going off of something that's subjective, that's not enough to make recommendations for more than one person. Sure, you can experiment on yourself, and that's great, but how is that going to help the community, right?
I feel like we see this all the time.
All the time.
Whether it's someone pushing a carnivore diet or being vegan or a certain lifestyle, it worked for them. How do we know it's going to work for you?
Exactly. So objective outcome measures, and that's how scientific method is really based off of. You know, it's hierarchy of evidence, looking at the whole body of evidence, not cherry picking studies, not looking at a rodent study and making this leap of faith that a peptide based on a rodent study is going to be good in a human being. So, or even less, in a petri dish, which is just an isolated mechanism. The human body is such a complex system. It has to work in synchrony, harmony, right? So just because it translates in a petri dish, by no means does it mean that it's going to translate in a human being. Not to mention so many other factors, looking at long-term safety data, et cetera. I mean, a lot of factors in medicine. There's a reason why medicine goes at a little bit slower pace than what people in the health and wellness industry today want it to go. It's because it's a process that requires a lot of data, a lot of feedback. I mean, I think AI is going to help us a lot and accelerate that path, but just got to be careful out there. I'm always slow to follow the latest fad trend, because you know, like the CBD trend, right? It was
people don't even talk about CBD anymore.
Right, but it cured everything before, right?
Yeah.
And now people don't talk about it.
Yeah.
So we got off track. I forgot what we were talking about.
Okay, it's good. I want to get into peptides, and
Okay.
before we go there, what are certain things that you're really bullish on right now?
I'm bullish on the boring stuff.
I love it.
But I was going through my lifestyle pillars, or my pillars for my action plan for all of my patients.
Yes.
Lifestyle optimization matters most. You got to get that dialed in if you really want to see results and pull that longevity lever. So sleep, nutrition, and with nutrition, I look at it a lot more simplistic to start. Most people are overnourished, meaning that they carry excess body fat, most specifically organ fat and visceral fat, and that's very harmful for your body. Organ fat is an endocrine organ, meaning that it actually secretes hormones, inflammatory markers, inflammatory substances in the body, and that wreaks havoc on your body. It causes organ dysfunction, et cetera. So before people dive into the weeds on their macronutrients, their micronutrients, they need to be at an ideal body weight first, because if you're not there, all of that excess organ fat that you have is outweighing any potential benefit of you trying to dial in your macros, your macronutrients, micronutrients.
Sleep,
so
make
nutrition,
sure you don't have extra body fat.
That, get plenty of protein, plenty of fiber, staying hydrated. Those are my biggest things with nutrition. I'm happy to talk about more nuanced stuff with nutrition, but so sleep, nutrition, then movement. So maximizing your strength, your muscle mass, your mobility, your flexibility. So that's all under one bucket. Another one that's huge is stress and mindfulness, having a sense of purpose and community in life. All of these things combined in a package, when you optimize though, if you're doing all of those things, you're going to be in the top 1% of the population in terms of your health and longevity. The last little layer that I add in, because I am a medical doctor, is targeted pharmacotherapy. So drugs when needed, if lifestyle optimization falls short, or we've dialed in there and your genetics just didn't give you quite the hand that you needed to cover the rest. And we can talk about that later, but when I talk about, I say that I am very passionate about cardiometabolic disease prevention. So another thing we don't really do a good job of in modern medicine right now is very aggressive disease prevention. So we look at things, we've been looking at like heart disease, stroke, heart attack, stroke from like a 5 and 10 year perspective, when we should be looking at things way further down the line, like 30-year risk. Like there's no reason why someone should die from a heart attack or stroke anymore, even though it's the number one cause of death.
That's the number one killer, right?
Number one killer.
Wow.
And the reason is we're not intervening on this early enough, because heart disease, stroke, cardiovascular disease is a very slow and silent process.
Yeah.
And if you intervene early enough, just think about it like planning for retirement, right? It's compound interest. You should be, I mean, you're 30 years old?
I just turned 30.
Just turned 30. God, you're so young. You should be looking about your heart disease risk now, not whenever you have your checkup with your doctor when you're 50 years old, when you've already had significant plaque buildup. Like it just only makes sense.
And it runs in my family, so I'm like extra, I'm extra cautious about it.
Exactly.
I'm putting in that work every day because I'm like, I want to be playing tennis and doing jujitsu when I'm 70 years old,
Absolutely. I just took my first padel lesson yesterday.
Nice.
So
we got to
trying to get into it.
Oh, that's great.
I don't play racket sports, but I'm going to learn.
Oh, they're so fun. A lot of studies on racket sports being great for the brain as well and longevity.
I believe it. There's a lot going on there. Yeah.
Okay, so let's circle back. Supplementation, is that a part of optimizing your...
Sure. Supplements in the right circumstance make sense. So I don't blindly recommend supplements to any of my patients. There are some exceptions. I would say there's one supplement that's benign, meaning it's harmless in the majority of the population, with the exception of those with kidney dysfunction. There may be others, so don't 100% quote me on that, but to my knowledge, so creatine is fine. It's a good supplement for anyone to take blindly, because there really is no specific outcome measure that you can measure for that other than strength, performance. You could do muscle biopsy to see if you're having improvements there, but not a direct correlation.
Male, female, I know some females have resistance in terms of the extra water weight, and there's like a fear around.
Yeah, I wasn't aware that there was that, but so either way, I mean, I'd say so there's creatine monohydrate and creatine hydrochloride. If you're more concerned about the water retention, for me, and I think for most guys, because it goes straight to the muscles, it makes your muscles look fuller. So I think that's a bonus. But if you're more worried about water retention, creatine hydrochloride has less water retention, but still has the creatine benefits for helping to strengthen muscles, energy for your muscles, et cetera. So
interesting. I didn't know that.
Yeah, hydrochloride, less bloating, less water retention.
What's the difference between the two? That's really just the only difference?
That's really the main thing. The dosing is a little bit different. Monohydrate is the one that's been studied more. Yeah. And so you have better outcome data with that, but I don't see a reason why you couldn't take hydrochloride if you're worried about the water retention.
Yeah. So creatine.
Creatine, yeah. So to improve your performance, so that you get better workouts to help increase strength, which in turn will increase protein muscle synthesis. At a low dose, 5 grams daily. There are some new studies out that are pretty interesting. Not a huge amount of data with this, but there are some signals that support that it enhances cognitive performance. Upwards of 20 grams. This has been very beneficial for me, especially whenever I'm sleep deprived, where I feel like the jet lag after I've woken up at an odd hour, I don't feel refreshed. I'll do my 20 grams of creatine. I'll actually do it either right before I go to bed or in the morning, or whenever I wake up. I mean, maybe it's the nocebo effect or the placebo effect from that, but I feel much more refreshed and cognitively on point if I take that a couple of days on a regular basis, if I'm sleep deprived, or if you have like a very challenging day and a large cognitive load in front of you, taking 20 grams of creatine. Now I'll caution this though, because everyone is different, and people one of the side effects of creatine can be some GI issues, so it can cause some stomach upset, loose stools. So before you jump directly from 5 up to 20, I would titrate up along the way, and don't just go straight to that, because you can get some pretty nasty upset stomach, just jumping from one to the high dose.
Yeah, it makes sense. I've never experienced that with creatine. Maybe that's just for certain people.
Yeah.
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 So I'm taking 5 grams daily right now. I've never had any issue. Yeah.
Yeah, I'd say, so creatine is one. Really, that is the only one that I blindly recommend. Another one that I think is pretty benign because a lot of people are magnesium deficient. So magnesium bisglycinate or glycinate, it's more so the glycinate, the glycine component to that has a nice calming effect that can help for sleep.
Yep.
And it's just, there's a paper that came out recently and it talked about like really, it's not the magnesium per se, it's the attachment, it's the salt attachment to the magnesium that's creating that effect that you want. So you can have magnesium in so many different forms, right?
Yeah.
So you need to get the magnesium glycinate or bisglycinate formulation if you want it for the calming effects, improving the quality of your sleep, taking it at nighttime.
When you say salt, that's glycinate is...
So magnesium glycinate is the compound together, that it comes together. It's not the magnesium itself that's causing the calming effects, it's the glycine component.
Gotcha.
Just like you can take, there's magnesium oxide, there's magnesium taurate, there's magnesium citrate, there's a million of them.
Yeah.
But yeah, for the sleep, I recommend that. I like to look at everyone's supplement profile to make sure they're not overdosing on certain supplements because they can add up. You may not even know that one supplement contains this or that, especially if it's got like a proprietary blend. But magnesium is pretty benign, and I like magnesium glycinate. So those are probably the two. And then the rest is based on deficiencies. Like I will test.
What about electrolytes?
Like what kind of electrolytes?
Like just starting the day off with an electrolyte, you know, magnesium.
Okay.
So
I may make some of your followers hate me. I think that's.
Tell us.
I think electrolytes are total BS.
Really?
Yeah, and twofold. One, because if you are adequately nourished, you're going to be getting the electrolytes that you need in your food. If you're eating a wide variety of fruits and vegetables, those electrolytes will be there. You just need to hydrate, right? The exceptions to that would be, so someone that is like sweating a ton, like running marathon, like tons of sweating, then electrolyte repletion can be beneficial. I'd say for the most part, they're benign with the exception,
hydrate.
I'd say they're benign with the exception of like the ones like Element, because they've got 1,000 milligrams of sodium per serving. That's nearly half. So the RDA recommendation for sodium is 2,500 milligrams. And Element's big thing, and you look at their study, it supports, that we're undersalting people. But if you understand how to critically appraise research and look at the whole body of evidence, that couldn't be more false. So salt, a lot of people are extremely salt sensitive. One of the biggest driving factors for hypertension is sodium. So sodium retention causes hypertension or high blood pressure. So if you're getting half of your or near half of your RDA intake in one electrolyte drink, and then you eat out on a regular basis, you're going to far surpass that level.
Wow.
Some people,
so someone who already has high blood pressure even be more sensitive to
potentially, if you're sensitive, if your hypertension, high blood pressure is driven by sodium, a lot of people have genetic SNPs or single nucleotide polymorphisms that put them in a position that they're very salt sensitive and it raises blood pressure. Some people do not. Like, take for example, I know Peter Attia is not popular anymore, but I think he's actually one of the founders, or he's got some connection to Element. But
there's a bunch of the big guys on it.
A bunch of them. And
if you don't know why Peter Attia is not popular anymore, go do some research at home.
Anyways, so he even mentions this, and he discloses that he normally has low blood pressure. So for him, it's not really a big deal. But for someone, a good majority of the population is salt sensitive. And there was a recent study that came out that talked about what are the best ways to naturally lower your blood pressure. Actually, the number one way to do that is doing something called a DASH diet, which is a low sodium diet, primarily of fruits, vegetables, legumes, certain types of dairy that are naturally low in sodium. And that has been shown to drop your systolic blood pressure the most, upwards of 8 millimeters of mercury. So if I'm going down a rabbit hole here, but what I'm saying is just blindly taking an electrolyte drink with 1,000 milligrams of sodium without doing your own research and homework on yourself is not a good idea. I'd say experiment with it, right?
Yeah.
Most people like your age don't have a blood pressure cuff. You should be checking your blood pressure if it's normal, okay, once a month. If it's abnormal, you should be checking it at least once or twice a week.
Wow, I should be checking mine once a month?
You should.
Wow.
Yeah, and it's easy to do. Like if you have the Whoop Life, like I do now, you can calibrate your blood pressure. It checks it every morning. It's pretty accurate as long as you calibrate it. But do an experiment on yourself. Like everybody is an individual. Yeah. So some people are not sensitive to salt as much. So maybe you can handle electrolyte drink. But the question is, why do you need so much sodium? Unless you're running a marathon. You don't need that. If you adequately hydrate, you're eating a well-balanced diet, you're getting those micronutrients. It's just an expensive supplement that's really not doing much for you. I mean, if you like the way it tastes or whatever, great, but it's not making you any more hydrated.
I like this take because you don't hear this take often. To me, it's so fascinating how, salt became such a big thing, right? It was the buzzword, salt, salt, salt. Salt is good for you, it's not bad for you. And I've seen people really pushing starting your day with these electrolytes, which have 1,000, milligrams?
1,000 milligrams.
Yeah, 1,000 milligrams of sodium. Honestly, I got to check the one I take. I've been taking Promex. I got to see if it's 500 or 1,000, but I've been starting my day every morning.
Yeah, you're going to get plenty of your RDA recommendation of sodium throughout the day. You don't need an additional.
I'm generous with the salt. I love salt. So
that's fine. Maybe you're not sensitive to it, but regardless, at worst, it's causing harm. Yeah. At best, it's just an expensive little elixir that's not providing benefit because you're getting all of those micronutrients throughout the day through your food and water intake.
Yeah. So we're going into this. I love this. For you in the morning, I know people say we wake up dehydrated. You're not doing an electrolyte. Is there any form of hydration in the morning? Are you worried about that when you first wake up?
So I'm not a big believer in in fasting per se. If it works for you and it helps drive you in a caloric deficit, so you're eating within that window, I think from that perspective, it can have tremendous benefit. Now, where I think fasting has true benefit is not necessarily like the strict window or the time, but more so making sure that you're not eating several hours before bed, because that can bring up a number of issues. So I always refrain from eating several hours before bed. But it's in terms of the hydration thing you're asking me is, I'll wake up, you're asking me, like I have no affiliation with them, it's just a random protein bar. I'll have like an IQ bar. Okay. It's got plenty of electrolytes, micronutrients in it, a little bit of protein, a little bit of fat. I have that, and I drink some water, and that's literally the same thing as drinking an electrolyte drink. And it's got some good simple carbohydrates because I'm about to hit the gym. And my muscles need glycogen so that I can, optimize power within my muscles, so I have more, increased, protein muscle synthesis, etc. So I'm not afraid of eating something early in the morning whenever I get up, and I usually do. But I do refrain from eating later in the evening. I do have kind of a feeding window. I just stop eating, a couple of hours before bed. And there's a lot of science behind that in terms of additional benefit other than the caloric restriction stuff of the feeding window.
For sure. I want to touch on that more. I've noticed that personally on my own journey. I've been trying to cut off my eating and stop eating, before bed, give a few hours space there, and my sleep is for sure better.
100%.
Sleep is better.
Sleep is better. So your body, working on, and you'll appreciate this, you're wearing the glasses, with your circadian rhythm, as your melatonin rises in the evening, as the sun goes down, insulin and melatonin oppose one another. You develop more insulin resistance as melatonin rises. So if you have insulin resistance, that means that your body can't utilize glucose appropriately. It's the lock and key method. So insulin is secreted by the pancreas, and its job is to tightly regulate blood glucose in your bloodstream and allow it to enter your cells. So sugar can't enter your cells except for muscle. It can enter muscle during like aerobic exercise or in exercising. But most tissues, you need insulin as the key to unlock the door to allow sugar to go in. Melatonin and insulin oppose one another. Insulin doesn't work as well as melatonin rises. So if you're eating a meal that, especially that has carbohydrates in it, it's not going to partition the fuel as well in the evening time. That, and then there's the digestive issues. You want to be focused on, getting good restorative sleep and not working, your body's working on digesting while you're in the sleeping state, right? You want, the growth hormone and all those things to rise appropriately. You don't want to be focused on another component, which is digestion. You want that battery charge, right? So that's the main reason why we talk about not eating late, and it throws everything else off. So for all of you fasters out there that are struggling with that, and I deal with a number of patients, and part of what I do is I do lifestyle coaching, on a weekly basis. So the feeding window, the people that are fasting, a lot of people, they'll eat late, they'll wait to eat until like noon or 1, and then they'll have that feeding window of like 8 hours or whatever, and then they eat a late dinner, whatever. That's actually not good. Like if you could just take that window and slide it over to the morning time and then cut off much sooner, you're gonna have more health benefits from that.
It's the same thing, you're just pushing it earlier.
Correct.
And I've been guilty of that because I think there was this huge push for a long time talking about how beneficial it is to fast and fasted training, and naturally you're just like, oh, I'll fast in the morning. Right. I'll have my coffee, I'll work out, I won't get hungry for a few hours.
Right. And you can do that. You can definitely do that. And I think like having the caffeine, the coffee, the working out, it really does suppress your appetite. But I think you're missing, the bigger picture is, well, when's your window gonna be? It's probably closer to sleep. So it's gonna sacrifice your sleep. And not only that, if you don't have fuel in your body, especially carbohydrates, or more fast burn carbohydrates, not slow burn carbohydrates, that your muscles can utilize right away, you're robbing your muscles of fuel that they could be using to enhance your performance.
For the actual workout.
For the workout itself.
Yeah, that makes sense. So going back to not eating before bed, what's your window? How many hours do you recommend?
I'd say start off with 2. I aim for 3, but 2 hours I think is more than enough time. You don't want to be like too aggressive up front if you're not doing that, but 2-hour window would be a good place to start.
Where my mind goes, because sometimes when I do this, I do get a little hungry before bed sometimes, and I want a snack. What are your thoughts on that?
I think it's fine. What do you tend to snack on?
My go-to snack is usually a little bit of Greek yogurt with some honey and some blueberries.
I think that's fine. Actually, if you want to like really geek out about it, and
I would like that.
I do it sometimes when I'm hungry. I usually have a couple kiwis on hand because they have natural melatonin in them, or converted to melatonin, can help with sleep. And then since they have the sugar and stuff to help blunt that glucose response a little bit, this is overkill. But you can also do like take an exogenous ketone, that helps blunt the sugar response.
What's the correlation between that?
So just the exogenous ketones, so you get ketone bodies. Yeah. So that you can take that. So sugar, for whatever reason, it helps to improve insulin sensitivity, and it blunts the sugar response. I don't know the exact mechanism.
So like ketone IQ,
Ketone IQ, I forgot the other brand that I like. Yeah. But yeah, it will help. I'm not a big fan of like continuous glucose monitors, all that stuff. Yeah. I think it leads to really just like fear, fear around eating, and it really misses the point. But like just a nice trick is if you're someone that has trouble getting to sleep, kiwi can help a little bit from the natural melatonin.
I love this because I love kiwi, so this is good.
An added benefit. Yeah. Eat kiwi whole.
Yeah, with the skin.
With the skin on it, that extra fiber, and with the extra fiber will blunt the sugar response too. So you don't have as much. Because remember, in the nighttime, insulin is not working as well. Yep. So anything you can do that can help kind of modify the absorption at a slower rate so your body can handle it better,
Yep.
it's a good thing.
I love that. I have so many questions for you, but we're going to circle back to the peptides because we brought that up a little bit earlier. What are your thoughts on peptides, Dr. Joel? Need a sip of water for this one.
I need a sip of water for this one. Well, let's start off by talking about what are peptides. So peptides are a short chain of amino acids that your body already produces. These short chain amino acids send signals within your body to allow it to carry out a function. Peptides have been around for over a century. So insulin is a peptide. So people don't know that. There are
I did not know
a
that.
number of peptides out there. So all of these new weight loss drugs that are out there, semaglutide, tirzepatide, retatrutide, those are all peptides. So I put peptides in two buckets: those that are validated by good quality scientific evidence, and then those that are not. And whenever I say good quality scientific evidence, meaning that there's good human clinical outcome data on that. So semaglutide.
What does that mean in simple terms?
So think about evidence as a pyramid, a hierarchy of evidence. So at the bottom, so stuff that's not as influential and would not give me as much confidence would be stuff that's done in petri dishes, okay? So mechanistic data, so it's cells, and then the mechanism makes sense, but it's called in vitro, meaning that it's not, it's in a petri dish, but it's not within the organism itself. So it's a component that's isolated from the organism, okay? And then there are animal studies, so like rodent studies. Then there's observational data, meaning that you are looking for a specific outcome and you try to see a correlation with that. So for example, outcome, or this would be, observational data would be, does smoking cigarettes cause lung cancer? Well, we don't have any randomized controlled trials to support that because that would be unethical, but we have so many robust studies of observational data that we know that it's essentially causal. So you're looking at databases, you're looking to see if there's a correlation with a fixed outcome to see if there's causation. Unfortunately, observational data, for the most part, cannot prove causation. The next step up is randomized controlled trials. So that's whenever you take a placebo, let's just say for an example, a drug and then a placebo. So does this drug prove this particular outcome? Like for example, does, we can talk about this, does a statin medication versus actually lower the incidence of heart attack or stroke versus placebo? And
one group's taking it, one group's not.
One group's taking it, one group is not. So that's placebo controlled. And then randomized means that the patient does not know which one they're getting. And double randomization means that neither the person that's administering the study, they don't know, so that helps to eliminate bias. So if you double randomize it. So that's the highest level of evidence because it's in humans. The outcome hasn't happened yet. You're seeing it play out through time, right? And then on top of that are things called meta-analyses, which are a summation of a number of human randomized control clinical trials. And those are like the holy grail. And then from meta-analyses, we create clinical guidelines. And this is what medical societies create. The American College of Cardiology has a recommended guideline. The American College of Gynecology has their medical guidelines. And these are all based on not just one cherry-picked study, it's on the whole body of evidence. And that's what people need to understand is anyone can be very, very articulate and enthusiastic and have a narrative in mind, and they can cherry pick a study and make you believe it. But if you don't know what the whole body of evidence shows, if it's not replicated many times across different patient populations, then it can't be validated. So the thing with peptides, like especially like these research peptides that are out there, and I do deep dive on these peptides now because I have so many patients that ask me about peptides until I'm blue in the face. and so many patients that are going to be on them regardless of what I say. So I want to educate people, and I need to educate myself so that I can help keep them safe.
Yeah.
But the scary thing is there is very, very little human data on most of these peptides. Very little human randomized controlled trials on most of these peptides. And the biggest thing is there is essentially no long-term safety data on these peptides. And I can give you examples of individual peptides if you want, but that's my biggest quirk with this stuff is people are essentially experimenting on themselves, and they're using what we call anecdote, right? It's all anecdote. I feel better, I look better, my body composition is better. Well, that's great, but that's not the way that the human body works. It's nice. I mean, you feeling better does not ensure your safety. Okay, your anecdote does not ensure safety. Just because one organ system may be improving, it could be causing havoc on another organ system. Like for an example, I did a social media video on BPC 157. Okay?
Which is the talk of the town these days.
Talk of the town, right? So BPC 157, the mechanism, it's supposed to help with inflammation, recovery, tendon repair. It does something called angiogenesis, so new blood vessel formation, okay? Which would be beneficial to a site of injury or inflammation. But how can you guarantee that this peptide is going to isolate its angiogenesis to the target area? So say you bop your elbow, or you have tendonitis in your elbow, right? Even if you inject the medication, we now know that injecting in the site really does nothing. It's not providing any more additional benefit. If you do the injection, right? How do we guarantee that the angiogenesis is being isolated to the area of focus? Well, we don't know that. And in fact, there is some data, and this could be anecdote as well, but I was looking at like some Reddit post about a patient that was developing blindness because he was getting angiogenesis in his optic nerve. So he had to get anti-VEGF injections in his eye to reverse that by his ophthalmologist.
Whoa, that's crazy. Why that was happening? Because
he was potentially taking BPC, and he had blood vessel formation in an area that it shouldn't have been. Wow. Right? So it's not to scare people. And again, that's what I'm telling you is anecdote as well. That hasn't been proven, but what I'm saying is nothing has been proven in terms of the safety profile for any of these drugs. BPC has a total of like 40 people in studies. None of them are randomized placebo-controlled trials. 40 people in the entire world on humans, and people are injecting this stuff like candy.
Why? Where do you think the craze came from, and where are they basing the data off of? Because it's really taken the world by storm over the past 2 years.
Mechanistic data, so stuff in petri dishes, and they're translating rodent data and other animal data models into human beings, that's pretty dangerous to do that. So I'm not like anti-peptide, and if I'm pro innovation, and I think I don't have a problem with the fact that this stuff is being brought to our attention. People just need to do it in a smart manner, and if anything, it needs to be under the guidance of a supervision of a physician. And what I do with my patients is I try to create like medical guideline protocols. So for example, if someone is taking like a growth hormone analog to help, people take growth hormone peptides to increase muscle mass, lose fat, improve their sleep. But before you do that, you need to check certain biomarkers like an insulin growth factor. So if your IGF, which is the downstream effect of taking one of these, it's made by the liver, if it's already in the upper end of normal, why would you want to take something that takes you to a super physiological level?
Because that's probably not good either, right?
No, because growth hormone, although it may have some good benefits, you have to think about everything that it's doing. It can cause insulin resistance, diabetes. If you have cancer or small undetected cancer, it could grow the F out of your cancer. So none of this stuff comes without risk, but if you're it truly is experimentation. So if you're willing to take the risk and knowing this is truly an experiment on yourself, that's fine, but you should really understand the full picture behind all this stuff.
Yeah, it just seems crazy to me to do it without really knowing your blood work and where you're at already.
At least have an objective outcome measure. And that's what I try to provide for my patients that are going to take it regardless. I'm like, if you're going to take it, please take it under my supervision. Let me do serial blood work on you, check panels of blood work that make sense based on the mechanism. Let's have an objective outcome measure. Like if you're taking tesamorelin, which is a growth hormone analog. And that's actually a different scenario because tesamorelin has been FDA approved for lipodystrophy in HIV patients. So
what is that?
So for people get to help with fat, like excess fat. And it has been shown to help decrease visceral fat, organ fat. So, okay, well, if you're going to be on something like that, we should check like your IGF level to make sure that it's not like super high to begin with. Ideally, if yours is at the lower end of normal, then maybe getting to the upper end of normal may be beneficial to you. But again, I'm not endorsing any of this. I'm just saying. And then, but let's have objective measurements. Let's get a DEXA scan. A DEXA scan does a body composition test. It tells me how much organ fat you have. Let's see that it's actually improving rather than you just telling me that, yo, bro, I look shredded. I'm feeling better. Like, let's have some objective outcome measures. Let's check the blood tests that look for insulin sensitivity to make sure that that's on point. And that's just because you're improving in one aspect of your health that we're not declining in another aspect of your health. So all the more reason, if you're gonna do this stuff and you want to experiment, just be smart and find a doctor that understands the peptides and is willing to work with you, check your biomarkers, have objective outcome measures.
That makes total sense. It's more nuanced than just, I'm gonna get on a stack because I heard it's good from a social media influencer.
Right. Yeah, it's crazy.
So I know this topic is a little heated. I would love to get your opinions on vaccinations.
Oh gosh. Okay. What type of vaccinations?
Well, first we could start with maybe the COVID vaccines, and then we could go a little deeper into other vaccinations that kids are getting at an early age.
Yeah. This is not a topic that I'm super well versed on, so this is going to be more opinion based.
Yeah.
But I would say this, I have a very unique perspective on COVID-19 because I was on the front lines of this.
Yes.
I saw people your age, healthy, dying in front of me, their family not available to be in the room because they had to be isolated, literally saying their goodbyes on FaceTime. And that's kind of where you asked me, like, where did I make this paradigm shift?
Yeah.
I think that's where I really decided that I wanted to build something more along disease prevention.
Yeah.
COVID really took a huge toll on the people on the front lines of this.
Oh, I can't even imagine. Could I ask you a quick question, interjection on that? Were the people who were unfortunately passing away, were they metabolically healthy? Because you hear such mixed things.
Both.
And no one was really, I don't know anyone on the front lines.
Both. So you did see people that had, I think it's a mixed bag. There was always, the trend was either you already did have chronic disease and you were already immunocompromised, but I think there were people that were unhealthy to begin with, didn't have established disease processes, but this unmasked that for them. There is, strong correlation with metabolic disease, so I know that that's why you brought it up. But yes, I did see, and I will not forget this day, I saw a guy very fit, and I don't know what his past was.
Yeah.
He did survive, but he didn't do well. He's chronically debilitated after being on a respirator.
Aye.
So I think COVID really has a soft spot for me, and the fact that I was exposed to a lot of people really forget that COVID killed millions of people, millions. So when I look at the vaccine, and the data supports that the vaccine itself, did it prevent people from getting disease? No. But did it decrease the severity of disease, and did it help lower the risk of someone getting critically ill, going to the ICU, being on a respirator. Yes, it did do that. So I'm not saying that everyone needed to take the vaccine, but I think it did have its necessary place, and I do think that it actually did save lives. The topic of whether a young, healthy guy like you should, I mean, it's your choice. Of course, it's your choice. It's your body. But the incidence of disease processes that came from people from getting COVID, complications, myocarditis, all these things, long COVID and stuff, the number of these things, the incidence of these diseases, we call them sequelae, that happened, the aftermath of COVID, getting COVID itself far outseed, I mean, the incidence of complications from the vaccine was far less than those from getting COVID organically and having complications from it. So it's a hard topic to discuss.
Yeah.
And I think a lot of it is politicized. I guess I'll just leave it at that.
Yeah, that makes sense. It's a very charged topic. I appreciate your insight there. I mean, you were on the front lines. And I guess from your perspective, I guess my mind there goes to, I had it twice. Didn't really get that sick from it.
Right.
But a fit, healthy guy, I mean, put him to a really bad place. Why do you think that it's just the luck of the draw? Like
maybe the immunogenicity component to it, like everybody's biochemistry is unique. Maybe there's something particular about the virus itself that just it's just that piece of the puzzle, that viral introduction caused the immune system to go haywire. Maybe people's immune systems slightly vary.
Yeah.
So even if someone that does have quote unquote a healthy immune response, one variant of something being introduced to the body may be hypersensitive for someone and another one it's not. So a lot of it was the reason why people get sick is an overreaction of the immune system, right? There are a lot of there's genetic predispositions and there's a lot of chronic health predispositions that can amplify that risk. I don't have a straight answer for you. I just know that being metabolically unhealthy, having chronic disease exposure really amplified your risk for getting much sicker. But there was always the wild card. I would see someone that had nothing on their chart that was young and healthy. I'm like, why are you getting this sick? Like very, very sick.
Yeah.
But yes, hearing it from me, it did exist. I took care of them. And to this day, it really has just kind of changed my whole outlook on life.
Yeah, I can imagine, man. I guess I can't imagine what that was like. It's hard to imagine it unless you were there in person, seeing it on the front lines.
And the worst part of it, man, is the fact that we didn't know so much in the beginning. And, when someone is actively dying and you being alone, and I was literally, me and the nurse, the only person there with them to hold their hand. They couldn't be there with their families. I don't know that that's something that I'm going to be able to recover from, to be honest with you. Pretty wild times.
Yeah, it's so fucking sad, man.
Yeah.
Anyways,
on a lighter note.
On a lighter note. So let's get into some of the questions I had for you. What's something most people think is healthy but actually isn't, in your opinion?
Some electrolyte drinks.
Yeah, we already touched on that. That was a good one.
Okay. Saturated fat, beef tallow, butter. Those things are absolutely awful for your cardiovascular health.
Interesting.
Yes.
Wow, that's another one where the push has been beef tallow.
Right. And you're hearing that from grifters in the biohack space that have no clinical expertise. They don't know, either they have a narrative, they're trying to push something, or they don't know how to clinically appraise research. But so we can talk about this because this is something that I'm very, very passionate about.
Let's talk about it.
Okay. So from a dietary perspective, there's not a ton of things out there that are taboo, right? One of them, though, is saturated fat. Saturated fat will directly raise your LDL cholesterol and even more accurately ApoB. So ApoB, wait.
Yeah.
Go ahead.
No, go. Keep going. Keep
okay.
going.
I'm going to give you guys, this is an analogy that I like to use. So actually the new cardiology cholesterol guidelines just came out, and they are bringing up some good points, but I still think they have some room for improvement. So LDL cholesterol and ApoB is causal for heart disease. So let me just start with that. You do not need inflammation. You do not need insulin resistance to have a heart attack or stroke, okay? Those people that are telling you that you need those components, the chicken or the egg, we know there's insurmountable amount of evidence that supports that elevated LDL cholesterol is causal for heart disease.
Wow.
Okay? So LDL cholesterol is a measurement that we've been using that measures the concentration of cholesterol inside these particles, these LDL particles. Cholesterol cannot travel through the bloodstream on its own. It needs this spherical protein structure that transports the cholesterol. It's called low density lipoprotein, LDL cholesterol. The way that it's calculated in a lab is you churn that up and then you harvest the cholesterol concentration. The reason why that's not super accurate and it's more relevant in our society today is because we have a growing, obesity problem, a metabolic problem. And I'll touch on why that's important. ApoB, so I'm going to create an analogy. I want you to think about your LDL cholesterol like an M&M. Okay?
Love M&Ms.
Okay, I love M&Ms too. So the shell of your M&M is the LDL particle, that harbors the cholesterol. The chocolate is the cholesterol. The M on the M&M is ApoB. Okay? So you picture that you have different, this isn't the best analogy for this particular reference, but M&Ms come in different sizes and shapes. Then you got the mini M&Ms, the smaller ones, the bigger ones. So LDL cholesterol measures the amount of chocolate in there, but if you have really tiny M&Ms, what's the problem? You're not gonna have much chocolate, right? So your LDL cholesterol number is gonna be artificially low, but what drives heart disease is the number of particles themselves. But what does each M&M have? The M on the M&M. So it's the number of particles themselves, not necessarily the amount of chocolate inside is what drives LDL cholesterol. So you can have for example, a high ApoB level and a low LDL cholesterol. And the reason for that is one of the first things to change in our metabolism is the size and shape of these lipoproteins, LDL. When you become more metabolically unhealthy, these particles, the LDL particles, get smaller and smaller. Okay? So if you check your LDL cholesterol, just looking at the chocolate, not looking at the candy, the particle, the candy shell, it's going to could be low, right? But
It's not giving you the full picture.
Not giving you the full picture. So we have this thing, it's called discordance, where your LDL cholesterol can be not at an alarming level, but your ApoB can be high. It's the number of particles. So I love lipidology. I'll geek out on it all day, but just remember, you don't need insulin resistance. You don't need inflammation. It's the particle number itself that the particles that drive into the arterial wall. The arterial wall can be very healthy. In fact, it is healthy. These the particles can be big, small, it doesn't matter. Like there's this, people say that, the big and fluffy LDL cholesterol particles, those are safe. No, all of them can transcend through the particle wall given the size, all of them. So it's the number themselves. So what raises ApoB? What gives you more M&Ms? Saturated fat. Eating lots of saturated fat will raise ApoB. So what are things that are rich in saturated fat?
Tell us.
Butter is pure saturated fat. Ghee is pure saturated fat. Beef tallow. Fatty meats, right?
All the delicious
All
things.
the delicious stuff. And then, not to overcomplicate things, but it used to be thought, if you see people, I'll just give you some advice if you don't know how to critically appraise evidence-based research, and I don't expect 99% of the population to be able to do this, but if you see people with conflicting sides of the story, it's this, it's this. Science, the more you know about a topic, the more you understand that there's nuance to everything. It's never black and white in science, right? So it used to be thought that dietary cholesterol had a huge impact in the cholesterol that you see in LDL, ApoB. And then it swung the other way that no, it doesn't have any impact. So you can eat as many eggs as you want, right? Because eggs are super rich in cholesterol. Shrimp, you know. So for the majority of the population, dietary cholesterol has very little effect on your LDL cholesterol. That's the majority of the population. But there about 30% of the population, which is not insignificant, they're called what we call hyperabsorbers of cholesterol, and it does have a meaningful impact on your blood cholesterol level. So you could eat 7 eggs a day.
And be okay.
I could eat 7 eggs and it makes mine go up.
How do we find that out?
You could experiment, test it out yourself, eat eggs on a regular basis and isolate all the other food products to make sure that you're accounting for everything, and then retest your blood work. I always recommend doing blood work regularly. That's part of my
How often?
It depends what you're doing. If it's just maintenance and there's no intervention being made, every 6 months. If you're under targeted pharmacotherapy, hormones, whatever it may be, I may need to check it within a couple weeks, a month, but everyone's different. But I would say the general rule of thumb, the general population should be getting their blood work checked. And this is surprising, like every 6 months you should get your blood work done. And if not, at least annually. And don't wait. And if you're a younger population that's listening to this podcast, don't wait until you're 35 years old to get your first blood work checked. You need to be checking much younger. Like start getting your blood work checked in your early 20s. And if for anything, establishing a baseline of what your optimal levels are. Like what is your testosterone whenever you're 24, 25? If I had that information when I was 24, 25, it would be so invaluable because I know where my numbers would need to be when I was at my peak, optimal level output of testosterone.
Yep.
Now I have to go based off of signs and symptoms, et cetera. I don't know what it was, right? I didn't start checking my testosterone until I was 35 years old. So if anything, you want to check it earlier.
I wish I started earlier. I just started doing it.
Yeah.
And it's so cool to see, man. I've seen from my first test to my second test, I made some changes and I saw a difference in the blood work.
I love that, bro.
My testosterone went up. My ApoB was a little elevated. That went down.
You doing the Rhythm Health? Or?
Yeah.
Okay.
I went through Rhythm.
Okay,
and,
good.
so it was like, I think 3 months spread out.
Yeah. Yeah.
And I saw it in the blood work.
It's a very powerful tool to be checking things in real time. You now have objective outcome measurements rather than just going based off subjectively how you feel. Because a lot of these markers pay no attention to how you feel. You could feel great and your ApoB could be through the roof. And unfortunately, that's what happens. You know how many fit guys I've taken care of on carnivore diets that drop dead from a heart attack? All the time. I see this all the time.
Dude, I drank the Kool-Aid on the carnivore. So many people did.
Well, it's okay.
You see Paul Saladino once and that's it.
Poor Paul Saladino.
And he's staying true to it though.
He's actually not. If you look at it, no, his diet's changed. First it was only meat and now I'm eating fruit and he's had health issues. I mean, I'm sure he may not disclose that, but please guys, Paul Saladino, he's very articulate, he's very entertaining, but his information is false.
I love it. That brings me to my next question. This flows perfectly. How different can two people be under the surface? Like similar, two 20-year-old guys, both fit. How different can they be under the surface?
A lot. One good analogy that I like to use for that is, and this is entirely genetically predetermined. So how much organ fat do you have, which is what we call visceral fat. And I alluded to this earlier. A way that you can determine how much visceral fat you have is doing something called the DEXA scan. It does a full body composition. It tells you how much skeletal mass you have, how much subcutaneous fat, which is the fat that you see, and then visceral fat, which is what lines the organs. So I know you can tell me that you've seen a morbidly, we don't use the term morbid obesity anymore, but a very overweight person that doesn't have metabolic syndrome, or as far as you know, they don't have diabetes, right? Can you think of someone like that?
Yeah, for sure.
Okay, that's not on any meds.
Where they're
for
not
diabetes.
diagnosed with diabetes, for sure.
And then you know someone that's like super skinny that's diabetic. That's not type 1 diabetic, right?
Oh, yeah. Yeah, more than one.
Okay, so I'm going to tell you why that is. There are a number of reasons, but just to simplify things. So I like to use the bathtub analogy. So everybody has their own personal fat threshold. So think about the bathtub in your house as your safe fat haven for storage. Your adipose tissue, your subcutaneous fat. Everybody has a different size bathtub. Water is the fat itself being compartmentalized inside the fat tissue. So as soon as that water spills over onto the hardwood floor, it's causing damage to your house, right?
Yes.
So if you have a very shallow bathtub, it's going to get onto the floor easier and quicker, right? Because fat is all about fuel partitioning, right? So where is it being? It's excess calories that are not being utilized as fuel. So it needs to go somewhere. It either goes to insulation and fat that you can see, or it goes to organ fat, visceral fat, which is harmful. Everybody has their own different size bathtub. So if your bathtub is shallow, it's going to spill all out under the floor, and that represents your visceral fat. It's going to cause damage. But then you could have someone that has a huge bathtub. They can carry a ton of fat. It can store a bunch of energy, and it's relatively safe from a metabolic standpoint. Now, being overweight in general can cause other issues, but strictly from a metabolic standpoint, you can see people that do not develop. The main cause of insulin resistance is your organs get marbled with fat. It causes dysfunction directly to those organs. So, like I said, the organ fat is an endocrine organ, and it causes inflammatory particles to causes damage, oxidation and stuff within the organ itself. So your pancreas isn't going to work well. Your liver's not going to work well.
It's so interesting. I wonder why certain people have bigger bathtubs. Like evolutionary, was there
Maybe. But I mean, all of it plays together, right? I mean, you can't ignore all the other lifestyle tactics too, because that can accelerate the process. You get crappy sleep, you develop more insulin resistance. You eat refined carbohydrates all the time, you're going to, just refined foods, you're going to develop insulin resistance. You're not adequately muscled, muscle is the longevity currency. It's the kitchen sink for sugar. It's the buffer for sugar. Your muscles love sugar. So think about it like a buffer. The more muscle you have, the more metabolically flexible you are.
I was going to say, I've always been so, I crave fruit and honey, but I train really hard, and so I feel like my body is primed to take that in.
It is. And then for someone that's sedentary, that's going to create problems because that's energy utilization quickly, right?
Yep.
And if you're not utilizing that energy, your body's like, okay, I'm not using it, fat.
It's just train super hard, and you get to eat sugar. Get to eat all the delicious things.
What's your vice?
I love fruit. I love all fruit.
It's not a vice? Yeah. I thought you were going to say nerds or gummy bears.
No, I'm not I'm not a candy guy. No, dark chocolate I love.
That's not a vice, bro.
Yeah,
come on.
Honey.
You got nothing on you? Oh my God. Okay.
Good scoop of vanilla ice cream.
All right, fair. You ever had Bluebell? I'm from Texas. That's my favorite. Bluebell ice cream.
No.
Made in Bluebell, Texas. So good.
Soft serve or?
Soft serve.
Oh,
no, it's not soft serve. It's just out of the pint.
Okay.
Yeah.
Well, maybe if they have it in Austin, we got that trip planned.
You'll find it in Austin.
Yeah, okay.
For sure.
Bluebell.
Vanilla.
Let me write that down.
Just plain vanilla.
Bluebell ice cream. Okay, guys, we'll get back to questions here.
Okay.
What are some of the most important biomarkers people should actually be tracking?
There are a number of them. I already talked about before ApoB. Mm-hmm. If you want to play the long game to reduce or even eliminate your risk of ever having a heart attack or stroke, knowing your ApoB, that's the most accurate representation of the number of bad cholesterol particles in your bloodstream. So you got to think about that as not only the absolute number for ApoB, but the time of exposure. So how many years has it been elevated for? You multiply the two together. So if your ApoB is living at 150 for 20 years, as opposed to 70 for 20 years, I'm not the best at math, but that number is a lot higher, right?
Yeah.
For 20 years at the lower, or 20 years at the higher number than 20 years at the lower number. It's a long game.
I never thought about the time of exposure.
Time of exposure is the driving, that's how atherosclerosis, which is plaque deposition in the arteries, that's what the term is used for. That's how it happens. It's not like an overnight thing. So you just checking your ApoB in a short frame of time, it's useful, but you have to put it in context. What's your exposure through time? That's what you really need to worry about.
That's why you really need to do your blood work.
You got to do
early
your blood
and
work.
often.
Exactly. So there's ApoB and then Lp(a), which is another cholesterol component. So Lp(a), think about that. It's like a little crinkle that sits on top of the M&M on the ApoB that's really, really sticky, and it's upwards of 6 times more atherogenic, meaning that it causes mischief 6 times more than one ApoB. So it's like much stronger, causes much more plaque aggregation. And you only need to check that one time in your life because it doesn't change. After the age of 12 or 13, it stays the same, and it's very important that you know it because it's 100% genetic predetermined.
Wow.
And it's not influenced by diet, exercise, nothing. There's nothing that you can do to drive it down.
Wow, so it's fully...
It's locked in. The one caveat to that, it is an acute phase reactant, meaning so if you get sick, it can be falsely elevated for a short period of time, so make sure you get it checked whenever you're like healthy, feeling good.
Does that show on a normal blood panel, or do you have to
No.
get a specific...
No, most now it's in the new cholesterol guidelines. So it'll slowly be working its way in, and that just came out a couple weeks ago. But I guarantee you, your regular primary care doctor is probably not ordering that.
Yeah, that makes sense.
Other tests that are really important, VO2 Max. Now, VO2 Max is think about it like the size engine you have, okay? The bigger engine you have, the more efficient you are and the more power that you can produce. So it's the maximum amount of oxygen that your body can utilize to produce energy during your maximum output. How much oxygen can you actually utilize to create the most amount of output? And this is another big, like, I hate using the word Peter Attia, but Peter Attia emphasizes VO2 max, but that is probably the best marker that we have that supports longevity, lifespan, health span, because there's so many things involved into creating an optimal VO2 max.
I was going to ask, why do you think that is? I know it's become the staple for longevity.
Yes.
Why?
So think about it. What do you have to do to maintain it, to really have the highest output possible? Your central nervous system needs to be in check. You have to be coordinated. You have to have a really strong functioning heart. Your lung capacity has to be huge. Your circulatory system, your blood vessels have to be on point, providing adequate gas exchange. Your skeletal muscle needs to be on point, your coordination, all those things have to be working in synchrony and harmony in order to create that output.
Yeah, so there's so many different independent
Right.
health factors that all need to be firing
Correct.
efficiently.
Correct.
So it makes sense that if all of those are firing really efficiently and you have a really good VO2 max, you're going to be healthy.
100%.
That makes sense to me.
And then from a metabolic standpoint, a couple of them, most people can very easily get a fasting insulin level as opposed to just getting a hemoglobin A1C. Hemoglobin A1C is a representation of how much sugar is attached to your red blood cells over about a 3-month period of time. There's a lot of variance to that. And I actually have a little bit higher hemoglobin A1C. It's almost like the pre-diabetes level, but there are a lot of things that can skew that data, the size of your red blood cells. So if your size is off on the red blood cells, they get turned over quicker or slower by the spleen. So a better representation is fasting insulin, because if your insulin is taxed, that means that your body is pushing harder to maintain that tight window of blood glucose. So you have a fasting blood glucose, probably like the lowest on the totem pole. Fasting insulin is definitely better because that tells me it's masking what the blood glucose is showing us, right? The blood glucose is staying pretty constant, but if your insulin is rising, your fasting insulin is rising, that means that your pancreas is working overtime. So those are signs of insulin resistance.
Gotcha. I kind of get that. Break that down a little bit differently, maybe in simple terms.
So simpler terms. So in order to create what we call homeostasis, your body needs to keep your blood glucose in a very tight window. Like most people, their blood sugar stays within the range of like 70 to 150 to 180, even after a meal. Very rarely does it get outside that window. That's miraculous for your body to do that. Once you start becoming diabetic, the numbers can skyrocket. Okay. In order to create that tight window, you need that key to unlock the door to allow sugar to enter the cells. Insulin pushes sugar inside the cells. So if you're constantly eating, let's say you continue to eat and eat and eat, right? So that energy, that sugar is entering your bloodstream. So if you didn't have a way for the sugar to enter the cells, it would just continue to rise. You need insulin to open up the door to allow it to go inside the cells.
That makes sense.
And the less insulin that you need to do that, the more sensitive your insulin is. The more insulin you need to utilize to do that, the more insulin resistance you have. It's an efficiency thing. And that's a good marker because you're not going to see it by checking a random blood glucose. You're going to see it by way of insulin, because if your insulin's working hard, your insulin's masking it, right? It's saying, hey, everything's fine. We're keeping our numbers within those ranges, but I'm having to put out a lot more insulin to do the same job.
We don't want that. We want it to be efficient.
We want it to be efficient.
That makes sense. Would LDL be on the list as well?
LDL is trumped by ApoB. ApoB always wins over. If there's ever what we call discordance between LDL and ApoB always wins.
Gotcha. Is that why? Because I know recently there was this whole push on LDL, and it's not actually bad if it's high. It's misunderstood.
Yeah.
Was that the reasoning for that?
No, that's probably from a lot of misinformation, people.
Yeah.
There is some nuance to that. Like I said, if there's discordance with a normal LDL cholesterol and a high ApoB, it's that usually with that analogy of, and I'm not going to go into the weeds on this, but people that are metabolically unhealthy, the size of their LDL particles starts to change. They get smaller and smaller, so they harbor less and less cholesterol. Okay, but the particle number actually goes up. Okay. So the LDL cholesterol, which just extracts the chocolate in the M&M, the actual cholesterol itself looks artificially low, but the particle number's high. And I wasn't going to add another one onto metabolism, but what I do with my advanced testing is something called LPIR, so it's called lipoprotein insulin resistance. And the reason why I order this test, it's looking at the sizes and shapes, the morphology of these lipids, okay? How big is your LDL cholesterol? How small is your HDL cholesterol? Okay, that is insulin resistance and cholesterol are baked into one another. Actually, the very first sign to change before fasting insulin is sizes and shapes of the lipoproteins. So we see this pattern of really, really tiny LDL particles. That's telling me that you're developing metabolic syndrome and insulin resistance. And I can see this many years in advance, well before your blood sugar starts to rise. So this is where medicine is going. It's more telescopic view into your health and very aggressive disease prevention.
So seeing the sign of
before the tests that are like standard tests now, we're seeing signs well before that.
Wow.
Way further upstream.
And then you can
intervene earlier.
Yes. Then you can optimize your life to
100%
take action there.
Right. And at that point, you don't need meds. You just need to adjust things in your lifestyle.
I like that. Damn. I think I got to work with Dr. Joel. How much of modern health issues come back to stress?
Ooh, I mean, who's not stressed out these days, right? Yeah, I think a lot, actually. So a lot of stress is if you don't have an outlet for it and take care of it habitually on a regular basis. That's why one of the pillars of health span is stress and mindfulness reduction, meditation, deep breathing, sauna, journaling, having it, sense of community purpose. If you don't have that outlet for stress reduction, you get chronic uptick in cortisol. And cortisol is a hormone that's produced by a gland in your body called the adrenal gland. And it can wreak havoc. It causes what we call a catabolic state, a breakdown state. You've heard the term anabolic, like steroids, which makes you bigger. Catabolic is a breakdown. So a chronic catabolic state, but it does it in a bad way. So whenever you have lots of cortisol, it starts breaking stuff down. It breaks down muscle tissue, okay? So it'll break down muscle, and it'll tell your liver to take those muscles and amino acids and turn it into sugar, okay? So not only do you lose muscle, you start having loss of muscle and redistribution of fat into the organ fat, the visceral fat, more belly fat. It causes hormone disruption. It causes disruption on the brain organ axis of hormones. So it lowers testosterone.
Sounds like a freaking nightmare.
It's not good. It's not good if you don't have your cortisol in check.
Yeah. And I guess, why do you think that happens? I mean, evolutionary, we weren't supposed to be in a chronic state of stress, right?
True. I think because we have like these chronic stimulations of dopamine with scrolling through social media, we're constantly in that dopamine hit phase. We don't know how to shut it off. We're constantly exposed to blue light. We mess up our circadian rhythm, and cortisol flows with our circadian rhythm so well, right? You want to have that nice sharp rise in cortisol in the morning to wake you up and slowly digress throughout the day. That's the rhythm that you want. But if you're having all these outside stimulants in your life, that can really disrupt that.
Yeah, it's such a chronic issue. We see it all the time. And it's not easy with the world we live in.
100%.
It makes it challenging. Yeah. Okay, I like this one. When you think about living longer, what actually matters most? We kind of touched on this a little bit.
Yeah. I'm just going to keep this simple. Move, exercise, build strength, muscle. Really prioritize your sleep. Make sure that you are at a healthy body weight. Do the stress mindfulness tactics to help, have a sense, enjoy your life, right? And have an outlet for stress. One thing that I didn't touch on was some other environmental stressors, like don't smoke. Nothing. Like
no vaping?
No. Anything that like causes combustion and it goes inside your lungs is a bad thing for the lining of your lungs. The blood vessels in your lungs is just a no-no. Doesn't matter what you're putting in there. Obviously, cigarettes is way worse, but
yeah,
if you're gonna do it, choose a different vector, right? Choose a different vector if you're gonna do it. So I would say smoking, and then another one that I think we're, especially like the younger generations like you, alcohol, man.
Yeah.
Alcohol, we now know that there's no amount of alcohol that's good for you. The least amount.
You hear that, guys? That whole one glass a week, 2 glasses a week, it's good for your heart health, red wine.
No, I think that data is definitely misconstrued, and it's got a lot of bias because, healthy user bias with that. I will say this, though, you have to live your life. If you truly enjoy alcohol, just limit the amount that you do drink. And, but if it's something that you truly enjoy, just limit it. And then be strategic about it. Just like eating late at night. The same thing with alcohol. Even a small amount of alcohol really disrupts the quality of your sleep. So the earlier that you drink the alcohol, the better. Like try to avoid drinking it late at night. Doing all of those things, man, most people do not do that. They don't get their sleep dialed in. They're not strength training. They're not in an ideal body weight. They're not doing stress and mindfulness tactics on a daily basis. They're not avoiding alcohol. If you do all that stuff, I promise you're going to be way ahead of biohackers that are putting MCT oil in their coffee, butter in their coffee, whatever. Like, stick to the basics. You do the basics and you do it consistently, you will be in the top 0.01% of the population.
You're making me feel good, bro. I mean, I'm in the 0.01% then, man. I'm doing all those things. Going off, I know we talked a lot about movement and strength training, mobility, flexibility. We didn't really touch on cardio or cardiovascular health. What is your take there?
For sure. I mean, I think there's a huge component of that as well. If you're playing the longevity game, so again, building that VO2 max. Think about your VO2 max. I like to use the pyramid analogy for a lot of things. So doing zone 2 training, and think about zone 2 training as the base of your pyramid. So the bigger base you have, the bigger apex you can get. So think about zone 2 training as your foundational cardiovascular output. So zone 2 training, for simple purposes, is it's trying to maximize oxygen utilization in your mitochondria before you start switching over into anaerobic metabolism, which produces lactate. So energy is extracted from oxygen. We have different mechanisms that shunt away from that once that system shuts down, and we're like moving too fast, and we get that lactic acid. So you get lactic acid build up in your muscles and stuff. But if you want to essentially train and beef up your mitochondria, which is the energy, the powerhouse of your cells, you do zone 2 training. So zone 2 training is roughly 140 minus your age is around, 180 minus your age is around the heart rate that you want to be at. So for me, like around 104, I want to sustain a heart rate of around in the 140 range. As you become more conditioned, that number can rise higher. And then if you have a smartwatch, it actually does a pretty good job of doing the zones for you.
Yep.
If you have a hard time, and if you don't have access to like a smartwatch, it's going at a pace consistently and not deviating from that where you can talk, where it just feels uncomfortable.
Yep.
So that's zone 2 training. So for me, I do incline on the treadmill a lot. At like 3.0, and then it'll vary on the incline. Everyone's different. Or a slow jog for me keeps me in zone 2. And it depends on where you're at in terms of your fitness level. For some people, like I have a good trainer friend of mine, he can like literally like run, and he's in zone 2. So
I've done a lot of that work. I could pretty much run or
Okay, so
cycle
you're there.
hard in that. Keep it that 150 number.
Right.
It took me time though to get that. I mean, I played soccer my whole life and was always relatively cardiovascular, fit, but I had to train specifically zone 2 to get that.
Exactly.
Yeah. So you're saying that's the bottom of
That's
the
the
pyramid.
base.
That's a bit.
Aim for, I mean, if you can get 180 minutes a week, you're doing it well. I mean, that's a lot, but
I'm getting that.
And then obviously you got to do some of the HIIT training and zone 5 training to really get that peak performance, that maximum output. So doing sprinting a couple times a week. So I aim for like doing 30 minutes of zone 5 training, which is, for me, that's like in the heart rate around the 170s to 80s. And doing sprints is really good. I'll do like, I will sprint for a minute, take a break for 4 minutes, sprint for a minute, and do a cycle of that like 4 or 5 times.
Nice.
That will help to improve your VO2 max as well.
And then the strength training, that's on top of it.
Strength training is on top of it. Yeah. And obviously you need that. And then the name of the game when it comes to strength training is also maintaining your mobility. And I know you had talked about like you do yoga and stuff.
Yeah.
That's so important for your mobility, flexibility. Because if you're not flexible, you're not mobile, you're going to get injured. And if you're injured, you can have really bad setbacks. The name of the game is never getting injured, because when you do, you really decrease your muscle mass whenever you're out of the game. And it's hard to recuperate, especially the older you get. So never have an ego when you're in the gym. Always train smart, because if you get injured, it's much worse than you trying to push yourself a little bit harder than you feel comfortable.
Yeah, totally. That makes sense. So I got 2 questions to wrap up here. If someone wanted to drastically improve their health in the next 30 days, what would you tell them?
I think we've already hit on this. Get your blood work checked.
Yep.
See what your ApoB is, your Lp(a). If you're high risk, it's okay. You've got time. It's time of exposure. Get a provider that can help map out a plan for you to get that that those numbers reduced. So get blood work checked. Get your sleep dialed in. That would be the most important thing. Be militant about having a really good sleep schedule, sleep hygiene. Limit your alcohol. I mean, we're getting better about it as a society, but like it's not okay, guys. It's really not. Like, alcohol's for the baby boomers. Like, we got to be smarter about this. Alcohol just really wreaks havoc on your health. So limit your alcohol consumption, dial in your sleep, get your blood work checked, and then just make sure that you're moving and building your strength, getting out there, seeing sunlight, enjoying life, having a sense of purpose. Those would be the main things that I would say.
Beautiful. Yeah. I like that. You hear that, guys? Do all those things. You'll live a good life. And the last question I ask every guest on the show is, if you could tell the younger version of yourself one thing in this moment, what would it be?
It's a good question.
You get to choose the age too.
I would say get involved with the inside of your health much, much earlier. And obviously doing the lifestyle stuff is what matters most. So developing a plan and simplifying your lifestyle pillars, but get your blood work checked early so that you know that there's no surprises down the road. If you check earlier enough and you just check even on an annual basis, you're going to be so far ahead of the game in terms of disease prevention, because I see this time and time again, and that's why I have a preventative practice. In emergency medicine, I'm putting out fires when chronic disease has gone haywire. If I could have talked to these people 10, 20, 30 years earlier and coached them and educated them, they would never be in this situation in the first place. So really educate yourself about your health, know your own physiology, know your own data, know your own blood work. And if you have a baseline there and you have something to go off of, that's a very, very powerful thing. And if it's okay if you don't understand everything. Get you a mentor that can help guide you through the process, but get that data early and you can go off of it. And it's much, much easier to intervene and make small tweaks rather than making these huge interventions later on.
It's a beautiful message, bro. I love it. It's inspiring me to keep doing what I'm doing and maybe even go a little bit deeper into that, right?
Absolutely.
Know your physio.
Know your physio.
Well, thank you so much for coming on, brother. I really appreciate it. And where can the audience find you? What's some good resources?
So I have my own independent company. I do work with Know Your Physio, so HealthSpan by Design. So you can go to healthspanbydesign.co, or you can follow me on Instagram, Dr. Joel MD, or just search Dr. Joel and I'll pop up. But those are the two best places to find me.
Love it, man. We'll link it in the show notes. I really appreciate you, brother.
Of course.
Until next time.